Now, our next speaker joins us from the Fraser Institute of the University of Queensland. I'm really thrilled that Tim can be here today to talk to us about the role of cloaking antibodies in bacterial infection post-transplant. His work as a senior research fellow at the Fraser Institute focuses on the interactions between the host immune system and gram-negative bacteria during chronic lung infection, with a specific emphasis on Pseudomonas aeruginosa. And his research uses a number of methods, including molecular microbiology, immunology, and genomic approaches. It's led to direct development of novel treatments in critically ill patients, and we've actually had the pleasure of working with Tim. One of my colleagues has called on Tim's help with a particularly complex patient who's been managed in Metro South. So thank you, and everyone please join me in welcoming Tim Wells to the stage.
Right, so first thing I want to say is I am a molecular microbiologist, not a clinician. So you'll probably see that in how I do this talk. So my interest really is in multi-drug resistant bacterial infections. My favorite one is Pseudomonas aeruginosa, but my lab and colleagues also work on other ones such as Burkholderia, Citrobacter, and a little bit of Aspergillus as well now. And so this is how what my lab tries to do is find new ways of treating multi-drug resistant bacteria. And we actually come at this from a bit of a weird angle by looking at the role of antibody in these patients. So, obviously antibody is good for you. Sadly, I have to say that now with anti-vaxxers. And obviously it can protect in three very broad ways: neutralization, opsonization, where you're calling in other cells. And then the one I'm going to talk about today is complement activation. So antibody binding to the surface of a bacteria and then attracting the complement system, which is really high in serum, but also, as you guys know, all through the body, leading to lysis of the bacteria. So what we look at, though, is that in some very specific cases, you'll get antibody that does the opposite of what you want. So it actually enhances the infection and protects the bacteria from killing. And that's where we can come in. So here you go, here's my little Pseudomonas. So just to remind you, on the outside of gram-negatives, it's made up of LPS, and LPS can be decorated by sugars that we call O antigen, and they're quite dense on the surface. So usually in complement killing, if you've got a serum-sensitive Pseudomonas, you'll get antibody binding to something on the surface here. It'll activate the complement cascade, and you'll get the membrane attack complex, this hole punch coming in and lysing the bacteria within about 15 to 20 minutes if it's really sensitive. So it's a great way actually to kill Pseudomonas if it's sensitive. What we found years ago is that some patients were making an absolute bucket load of antibody to these O antigen sugars of LPS. So they're making a ton of either IgG2 or IgA. It was in very high titer in these patients. It was very high affinity actually to this polysaccharide, which is a bit unusual. And when that happens, although it does activate the complement cascade, what it does at that point is it makes the membrane attack complex, but it becomes a physical blockade that prevents that membrane attack complex getting into the membrane. Okay, so we ended up calling this cloaking antibody because we like to think of it as the bacteria putting on a protective cloak around itself of your own antibody that you're making. So that's an interesting mechanism that we're looking at, but obviously it doesn't really matter unless it's leading to differences in health issues. What I will want to say here is it's not just against Pseudomonas. Pretty much any gram-negative bacteria that makes a polysaccharide, either capsule or O antigen, there's cases of this in the literature. So, like I said, I've got an interest in the lung. And when talking about Pseudomonas, you're really talking about people living with cystic fibrosis and other people with bronchiectasis as well. So years ago now, we looked at bronchiectasis and we could see a very clear, so these guys with the black circles, they're the ones that have cloaking antibody, very clear association with worse lung function than other people that were similarly chronically colonized with Pseudomonas but did not have this cloaking antibody. More recently, so we've looked into cystic fibrosis and we found fairly high prevalence. So when you're looking at the Pseudomonas colonized people in these cohorts, it's normally between 25 to, well, we've seen up to 60% of people that are making this antibody. In CF, it was 33%. And we've recently shown that the association with worse lung function in CF really is dependent on the IgA. So we've looked into the sputum and there's hardly any IgG2 in the sputum. So it's the IgA that's correlating with worse outcomes. So what we want to do next was look at infection with Pseudomonas post-lung transplant. And this started 5 years ago now, Chandima. And it all really started with a great little grant that I always like to mention, how these small grants can lead to big outcomes. So we got a Metro North collaboration grant, only 50K. And this brought myself and Amy, who's in the audience here, together with Chandima and Dan Chambers over at the Prince Charles Hospital to look at whether this is a problem post-transplant. And they have a fantastic cohort there of 129 patients that have had lung transplants up to 10 years ago, and that they've actually stored the serum samples for years, which is fantastic. So I could screen for cloaking antibody in these serum samples. We didn't have isolates for these patients, but when it comes to those O antigen sugars, there's really 3 that dominate. So we just screen against those 3 and see what we get. So it's a bit confusing here, but what you're looking at is 3 different sugars and the responses of all the patients. What you'll notice is the ones in black, they're the ones that are positive for cloaking antibodies, and you'll see that they're always clumps. So if it's up the top, it's IgG2. If it's underneath, it's IgA. And the clumps, what they're showing is the patient's serum sample. So that's a single patient with serum samples lasting years. And you can see that these cloaking antibodies are in high titers, and they actually persist. They persist for years after the transplant. So this was a really high incidence. This was, at the time, the highest incidence I'd found. So 40% of people had cloaking antibodies. So then we wanted to look if this actually affected outcomes at all post-transplant. So the first thing we looked at was incidence of these patients getting a chronic lung allograft dysfunction. And what we found, if you looked at the whole cohort, it was really clear and significant association that if you had these cloaking antibodies, you're much more likely to have a CLAD in the years post-transplant compared to those that didn't have these. Now, this was the entire cohort, and only about 80 of those 129 had Pseudomonas infection. So I did get worried that really this was just a bizarre test for Pseudomonas infection. So we also did this just looking at the Pseudomonas colonized cohort, but you can see that it was still a significant separation here, that if you had these antibodies, you were worse off. And this also was a risk factor for mortality as well, even considering multivariate analysis. So yeah, so what we showed that if you have these antibodies to Pseudomonas, you do have an association with worse outcomes. But that's not the only thing about this antibody. We've also been able to treat patients by removal of cloaking antibodies. So a lot of these patients with chronic lung infections, as you all know, they've got incredibly multi-drug resistant Pseudomonas. And years ago, looking at those patients with bronchiectasis, 2 of them had been in hospital for months already, and they basically, you could go to a salvage therapy to try to remove those cloaking antibodies. And that was successful. But I want to tell you about the case that we did here in lung transplant, and that was Jordan here. So he had cystic fibrosis and had received a lung transplant at Prince Charles. And post transplant, although initially it went quite well, he came down with a Pseudomonas infection in his lungs. And you can see that they treated here with the first round of antibiotics. And that cleared it for a few weeks, but when it came back, it was extensively drug resistant. And you can see here was when Dan contacted me to check if this patient had cloaking antibodies. There's a lot going on at this time, but it wasn't looking good for Jordan. So we screened that, or Amy, I should say, screened this, and found that they did have cloaking antibodies, and it was, their bacteria, if it didn't have these antibodies, was sensitive to complement killing. And so he did get plasmapheresis, followed by IVIG, in an attempt to remove, it's like throwing the kitchen sink, but remove those antibodies and then give them some protection in the IVIG. During that treatment, he did go Pseudomonas negative, and then recovered quite well then, and is still doing quite well today. So this has been done a few times since then. At the moment, it's still, a bit ad hoc. We have to come to me to screen the samples quickly and do it on compassionate. But we are at the moment putting together to actually try and do a trial in this to get some actual evidence of what the efficacy is. Oh yes, and you can tell this is a non-clinical talk normally, because I don't normally meet patients, so that was a big deal for me. Right. So plasmapheresis is not a great option for this when you consider how many people have these multi-drug resistant infections. But what it could be good for, and which is why we look at Burkholderia, is very rare but difficult cases. And with Burkholderia, it excludes you currently from lung transplantation and is highly multi-drug resistant. And so we've looked at what we, as many patients as we can get in Southeast Queensland with Burkholderia, and we have found that 4 of those 9 making cloaking antibodies that's protecting even different strains of their Burkholderia in their lung. So we're looking at whether it could be used in a targeted way, but a lot of what my lab does is actually trying to improve this treatment to be more specific. So I've already talked about the rare infections. One thing we're looking at now is whether you can remove just the cloaking antibody and leaving everything else out. There's companies that are doing this overseas at the moment, and we've shown in the lab that if you remove these antibodies specifically, you actually increase killing more than if you just put into IVIG or healthy control. So if you leave those protective antibodies in there still, it improves the killing of Pseudomonas. The other thing that we're looking at is synergistic drugs. So what we've shown mechanistically is that you need the antibody binding in this full cloak. So if you can affect that outer membrane of the bacteria just a little, it might not kill the bacteria, but if you affect that O antigen density or whether it makes it at all, you can lower the amount of antibody binding, and that restores killing as well. And obviously that would be a much easier way to deal with if you could just give them a drug at the same time that would restore their complement killing. And finally, one of my students is looking into specifically targeting these B cells because what we saw in a few of these patients, especially the ones with bronchiectasis, is that they'll clear the Pseudomonas, they'll stay antibody low for a few months, but then their B cells just start churning it out again. Cloaking antibody titer rises, and they have to get a second round of plasmapheresis. So we're targeting whether we can specifically target these B cells that are making this antibody. Right, so I was meant to talk a little bit about research opportunities. Basically, I'm very interested in any bacterial infections in these patients post-transplant. So if you've got a more detailed question about bacteria, please come and chat to me. In saying that, if you ever want us to screen patients quickly for this cloaking antibody, let me know as well. Email me and we can organize that pretty easily. This is my lab here. I just want to point out Amy, who did a lot of this work and is now actually over at the Prince Charles in the lung transplant team, research team, furthering this, and also Josh and Emma were the two that did that. But of course, with all my work, without the clinical collaborators, it would go absolutely nowhere. So I just want to really thank all these people here who have been vital to this success. So thank you.
Thanks, Tim, for a great overview of your work. Louise, have we managed to catch up a little bit? A little bit. I think we've caught up enough that there'll perhaps be time for one question about Tim's fascinating work. Anyone in the audience?
Yeah. Yeah, so this started in the UK, and those clinicians really didn't want to use that because when you use rituximab in people with RA, they get worse lung infections, and there's obviously a big overlap with bronchiectasis and RA, and so they weren't keen, but there has been talk of maybe using that over here, actually. So it's something that I would consider, yeah, because it would be, especially with some of the recent cases, how quickly, if you don't clear the Pseudomonas, how quickly that antibody comes back is an issue. So, yeah.
Sorry, quick second question. On standard sensitivity testing, these bugs initially appear sensitive to antibiotics, and you suspect due to lack of clinical response?
No, so they're drug resistant, but what I do test is that they are very sensitive to complement killing from anyone else's serum other than their own. So they're very complement sensitive in general, but the antibody that they're producing is protecting them in their own serum. So yeah, but most of them are extensively drug resistant.
I can confirm that Tim is very easy to find online when I was looking for his email to invite him to present to us today, and I'm glad that he accepted. For anyone looking for help with their complex patients.